The topic of your conference is science a public good? And I'll pick up this question by slimming down it from a huge question to a smaller question, or maybe also a more difficult question, by asking good for what? And that will have me talking about scientific worth in practice. So not scientific worth in the abstract, but scientific worth in practice. As we face the question, is science a public good? I will argue that it's good to see and to attend to the fact that science is not one. It's not a unity. There's not just one science, there are very many sciences, and they all have branches and sub-branches. And these may be good in relation to different goals, and they may have different downsides. So they're not equally good. They challenge us to unravel how, when, where, and in which ways they are good or maybe bad. Now, my approach rests on a shift that has been made in science and technology studies from appreciating science as just providing facts to science as generating and fostering practices. So whether science is good or not does not simply depend on the question whether the facts are true. Obviously, if facts are not true, it cannot be good. But fact being true may not be good enough. Because whether sciences are good or branches of science are good has to do with the practices in which the facts are embedded. I will illustrate this with 3 cases from research in medicine and healthcare. So I will not do the classic philosophical thing of arguing in the abstract, but I will be arguing through the concrete. And the concrete cases that I will talk you through are first that of kilocalories embedded in food, second that of atherosclerosis of the leg vessels, clogged up leg vessels, and the third case will be that of the predicament we're globally facing, COVID-19. Now let's start with the first case, that of kilocalories. Humans on average need 2,000 or 2,500 kilocalories a day. This travels as a fact. And how things travel as a fact, I've illustrated here with this image where this fact is put up. It says here, men need 2,500 and women need 2,000 kilocalories a day. We could talk more about that division, but I won't for now. Now, what does this fact mean in practices? Let's look at the first kind of practices, which are the practices that this fact comes from. So the research to find out the numbers 2,000 and 2,500 was done to confront situations of scarcity. What are minimal needs of human bodies? And these minimal needs come into view when people start to lose weight, when there is so little food that they have no longer sufficient energy. They no longer have, it doesn't any longer provide them with sufficient energy, as you see in the picture here, which is from the end of the Second World War, when even children in the Netherlands were severely hit by hunger. So when do people start to lose weight? That is where the kilocalorie numbers come from. But the problem is, who wants to know when people start to lose weight and what do they want to do with it? Some of the research into kilocalories was done in the early 20th century in the United States, and it was paid for by companies, by owners of companies who wanted to know what the minimum amount could be the minimum amount of money would be that they had to pay their workers so that they wouldn't lose weight. Now the workers, as you see illustrated or evoked in these pictures, weren't particularly pleased that there was research being done into their bodily needs. They didn't want to be paid on the basis of external research into their needs. They wanted to be paid in accordance with their demands, with what they wanted, with what they thought they needed to have a decent life. So even researching in that context already, researching the fact of the minimum needs was not innocent, was a particular practice. It was a practice related to how to set salaries. And in that practice, the 2,000 or 2,500 wasn't just an incontested, innocent fact. It was a particular, also political fact. Now, what is this 2,500, 2,000 good for? One of the ways it has been used is by armies to decide about the rations for the amount of food that their soldiers would need. Fine and nice, and it was an improvement for the soldiers, but because one of the problems in many wars has been that more soldiers died from hunger than from enemy fire. Now, this particular way of dealing with numbers has also been shifted to dealing with rations in food aid. So people in regions of the world that would be hunger-stricken would be provided with rations that were calculated on the basis of the caloric need of the human. Now, in one way, this is fine and nice, but if there is a sudden crisis, but in the longer run, if people get sufficient calories, that may not necessarily be what they want, because the way people relate to food in their daily lives is not just through calories, and they may well not want food sufficiency, but as it is called in this field, food sovereignty. And that means not just having enough calories, but having so-called good food, which may be the food that your grandmother ate, or it may be the food related to the land, or it may be the food that reminds you of good days. It has to do with what you can grow yourself, etc. and so on. What food sovereignty is for different people may differ, but it's really different kind of thing than just sufficient calories. Now, a third context in which the fact of the 2,000 and the 2,000 kilocalories travels is that of weight loss practices. And here you can see very well how the practice of the research is shifted onto daily lives of people. To figure out how many kilocalories people need exactly, experiments were done where different groups of people would get less and less foods. So a laboratory technician would weigh would calibrate the amount of kilocalories, would know which amount of kilocalories different groups would be provided with. And the people in the experiment, the human subjects, would have no access to other food, and they were put in a sort of artificial situation of scarcity, which allowed the researchers to find the exact numbers at which people would no longer lose weight. However, if this is translated to a situation of people who are overweight, or who think they're overweight, or who for one way or another would like to lose some weight, what is being done? They are told, don't eat more than 2,000 kilocalories a day, or don't eat more than, say, 1,800 or 1,600 kilocalories a day. But what travels there is not just a fact, it's also a practice. The research practice is shifted onto the eating practice. People are asked to be their own laboratory technician and to weigh the amount of food they eat and calculate the amount of kilocalories they eat, while at the same time they're their own research subject, supposed to not have access to other food. However, the problem with that is that this constant self-disciplining makes them focus on counting and not on feeling. And a lot of weight loss counselors that we have worked with in our research told us that in this way, people don't get the signal from their bodies that they have eaten enough, because they don't attend to their food, they don't enjoy it. So counting kilocalories may well be, in the particular context we're in now, not good at all, but bad, as it sort of is counterproductive in that it blocks people from having satisfaction and knowing when they have eaten enough. The second case we come to talk about is that of atherosclerosis. What is atherosclerosis? In the clinic, there are various answers for this. To simplify, I give you 4. In the conversation between a surgeon or an internal medicine doctor, a physician, and a patient, atherosclerosis of the leg vessels at least appears as pain upon walking. A patient tells, "Doctor, after I walk 100 meters or 150 meters, my leg starts to hurt. It starts to hurt really badly." That is diagnostic technique number 1 and answer number 1, pain upon walking. Diagnostic technique number 2 is that a technician or the doctor may then measure both the blood pressure in the arm and the blood pressure in the ankle and calculate on the basis of that whether or not there is a lot of pressure loss. If there is a severe atherosclerosis, the pressure in the blood pressure in the ankle is a lot lower than that in the arm. Third way of diagnosing atherosclerosis is by finding with a Doppler probe or a duplex probe a point in the leg where the blood velocity increases, so that due to the Doppler effect you hear a different type of tone. You hear boo, boo. So that's the third diagnostic technique, an increase in blood velocity. There's a fourth diagnostic technique, which is to inject contrast dye into a patient's arteries and make an oh, this is so difficult in English, you will empathize with that. Make an X-ray picture, an angiography. Now, these 4 different diagnostic techniques are classically understood as 4 approaches of one and the same object. However, if you follow them in detail in practice, they don't fully overlap. One of these things may be more severe, present, more apparent than any of the others. At the same time, and this is crucial for the shift to practice that we're discussing today, they're also different to do. To find out about pain, a doctor needs to do a patient interview and patiently talk with the patient. To find about blood pressures, you have to have blood pressure technology and somebody who can measure blood pressures. The duplex takes quite some time, and a technician who has a duplex apparatus and gel and a patient who's patiently lying. While the angiography depends on very complex X-ray equipment and a contrast dye. So these are different, not just facts that do not totally overlap, but also practices that have different requirements, different costs, different people who could do it. They also have different downsides. Let me compare the pain upon walking and the angiography, the most extreme in this case. The alleged downside of pain upon walking is that it is just a story. It is what the patient tells. And maybe as a doctor, you don't quite know whether the patient tells the things exactly as they are. They may think they have pain after 100 meters, but maybe it's 200 meters. Or this patient may tell their story different than the next patient. Or one patient may try to heroically hide their pain, while the other may exaggerate their pain, which makes pain upon walking a difficult kind of parameter to put into research articles, because it is a bit of a floating variable. Angiography, on the other hand, has very different downsides, because while it can travel slightly easier, you could look at it, it has the particular downside that injecting the contrast that is visible on the angiography is not just difficult and cumbersome and expensive, not irrelevant, but it's also potentially dangerous. Some people are allergic to the dye, and it does happen that people die from the procedure. And that is not what, as a good doctor, one would want, to have patients taking large risks just for a diagnostic practice. The difference between these ways of approaching, of doing, of performing, of enacting, as one may call it, atherosclerosis, emerges even more starkly when we take therapy into account. take an operation. In an operation, either the artery may be widened or it's possible to make a detour around it. Now, that solves the problem of the one stenosis that is being tackled if it's done well and if everything goes well. But if the patient goes out again and after a bit of revalidation starts walking, it very often happens that if they had pain after 100 meters in the left leg and the left leg has been operated upon, they now have pain after 150 meters on their right leg, or they get pain in their chest, etc. and so on. So what an operation does is solve a local problem in relation to a systemic disease. So it is good, it looks good on the angiography you might make of it, but it's not particularly solving the patient's problem that they cannot walk very long. Now the treatment on completely the other hand is walking therapy. So patients may be tasked to walk a lot, to walk at least 20 minutes at least twice a day. And that particular treatment doesn't solve the patient's problem from 1 week to the next, rarely even from 1 month to the next. But if somebody can sustain walking therapy for months and months on end, it gives a real improvement. It allows people to walk again for really serious stretches of time, and they don't get pain even after 500 meters, even after a kilometer. Neither in their left leg nor in their right leg, because both legs are trained at the same time, and walking therapy is obviously good for the heart and the brain and everything else as well. However, if you have a research design in which angiography would be the end point, it would be the parameter by which you decide whether the treatment has worked or not, then strangely and sadly enough, walking therapy comes out as not having worked. It works when you ask people about their pain, but you can't see any difference on an X-ray picture. So the question whether treatment works or not is not yes it works or no it doesn't work. Treatments tend to work for some things, they are good in some respect, and not for other things, they're not good in other respects, which falls back to our general question: is science a public good? Is science good? Is an intervention good? Is this way of approaching reality good? Is this way of living with reality good or not? It depends. Now, what this means in practice is that in hospitals, there are different ways of coordinating between different techniques, different diagnostic possibilities and different therapeutic possibilities that are good and bad in different ways. Some kind of coordination crystallizes out. Ideally, having faced the question, what is good for what? And in practice, this obviously does happen. People ask that question. But it's not always asked. It's also sometimes things happen just as they have grown to happen, as what has crystallized out from the past. And now we come to the third case, the third example of how science is not coherent, not one thing, which is the case of COVID-19. Now, COVID-19 I haven't researched as extensively as the other two cases, and the facts are, as you know, up in the air to a much more serious extent, and things haven't crystallized out so much. So this is a more experimental example, but at the same time, there's so much research being done and there are so many stories told that showing that there is not just one way of knowing COVID-19, but there are many ways of knowing COVID-19, and they have different suggestions as to what might be good to do. That case is fairly easy to make. Let's face one of the ways a question can be asked and then be answered in very different ways through different approaches, which is the question as to the spreading of the disease. What is the mechanism through which the virus that causes COVID-19 might travel? Now, very many researchers were obviously concerned with this sudden pandemic and have been doing research into it. And one of the disciplines that took up the challenge is that of the physics of fluids. Now, what these people studying fluids started to do is make very creative images of people coughing and sneezing, and they made images of the droplets that then travel from these people's faces out into the world. And what they told is that these droplets don't travel one by one, they travel in clouds, and jointly they may reach a lot further than previous research gave us to think. And the previous research was actually quite old. It had been done in the 1930s in relation to tuberculosis. So the physicist of fluids said that the rest of us shouldn't trust that old research into how far droplets reach, but should really attend to their new research and with them be concerned about aerosols and the way they spread quite far. Now, a very different way to study how virus may spread is that of virologists. The object of virologists is not fluids, the object of virologists is virus. And they study how virus behave in singular bodies, but they also study how virus spread between bodies. And they do this comparatively, so they would not take the virus causing COVID-19 as a totally new or a totally separate type of phenomenon, but they compare it with the spreading of the virus causing flu or causing a chest cold or the virus causing measles. And they say, wait a minute, if we look at the spreading under conditions of this virus, under conditions where people are not aware of it spreading, it still infects only around 2 to 3 people, while a virus that really spreads widely through aerosols, such as measles, will spread to far more people. So just looking at the aerosols is not enough. We need to look comparatively at different kinds of virus. So these two groups really have a different object, and it's not that one can simply said to be trying to falsify or deny the other. They just ask really different questions which have different consequences. Here I cannot easily say which one is good for what. This is up in the air, and that's one of the challenges that we currently face and have to grapple with. Another deep cleavage between different approaches in science that comes to the fore is the question of the evidence of effectiveness of preventive treatments. Which kind of preventive treatments are effective? Now, one of the moot points here is that of face masks. Are face masks effective? A classical way of clinical epidemiologists to try to answer a question like that is by setting up an experiment. So you would have a certain number of people using face masks in a population, and then a certain number of another population which would not use face masks, and then you would compare the numbers. One of the problems with that experiment, quote unquote, is that it's not easy to do in practice, and that there are very many confounding variables, that people do all kind of other things differently between two groups. So what rests there, and the other thing is you cannot simply set up an experiment and task people to do these things, because the social power to control an experiment in that way is simply lacking. And there are all kind of remarks to be made about older experiments that have been done in this way. For instance, if you do the experiments but neither group washes their hands, they're both going to get very ill anyway, and you cannot see whether face masks would make a difference on top of washing one's hands. So what rest is natural experiments. But when are natural experiments good enough? Or when are the outcomes of that good enough? Now, that has to do with a contestation not just about evidence, but also around what one might call effective or not. Some researchers think that intervention is effective if it works 100%. So if something really solves the problem rigorously, it works. If you have a drug that treats 95% of the patients with a certain disease, then that drug is effective. Is it effective if it this is has been particularly contested around virus in relation to vaccines. If a vaccine is only taken to be effective, or was by tradition, if really nobody who has had the vaccine will get the disease that they were vaccinated against. However, that kind of 100% effectiveness is maybe not necessarily required for preventive measures. This is not what I think, or it's not what I don't think, but what I'm trying to tell here is this is what another group of epidemiologists says. They say it doesn't matter whether a face mask works 100%. What matters is whether it at least slows down the spread of the disease a little bit. Effective is not yes or no. Effective is more or less. So if there is a promising reduction that a natural experiment would show, that is good enough to try. Then, in relation to COVID-19, there is yet a further very fascinating clash between ways of approaching. The dominant way of approaching prevention of in relation to this virus is trying to keep things clean. So this is an old 19th century passion in relation to infectious diseases to assure hygiene. Now, hygiene can be assured in all kinds of ways at the same time. You can disinfect hands, you can disinfect surfaces, you can try to assure hygiene by using proper face masks, by using gloves, by adding packaging on goods that you transport so that they cannot be coughed on or along the way, etc. and so on. Now, the efforts put into hygiene in all kinds of places in the world are really, truly impressive. However, what is silenced in that huge quest after hygiene is the cost in ecological terms. So ecology is not a discipline that we hear of very much in the whole COVID crisis, while at the same time, a lot of the materials used in striving after hygiene are themselves poisonous or polluting for environments. If all the inhabitants of a country start to use disposable face masks, things get messy. And they get even more messy if people just dispose of them on the streets or in the rivers, and they start to task the environments that already are tasked enough with, or more than enough, or far too much with all kinds of pollutants. But given the numbers in which both gloves and face masks are made, even if people dispose of them properly and they go into their own disposal system, this is really a huge increase of pollution. So on the one hand, people try to keep themselves clean and their surfaces clean. On the other hand, that effort of cleanliness is polluting in relation to another register, not that of viral cleanliness, but that of chemical cleanliness and pollution. So environments are heavily polluted. And about COVID-19, I have a fourth clash between disciplines approaching it, which is the question how to evaluate interventions made. Now, if interventions can measured, we came across this earlier, in laboratory experiments or in field experiments, but you can also here wonder what the disciplines are that are tasked to measure them. And this is very apparent in this particular case, that there is a huge clash between whether this should be a problem of counting disease or whether at the same time there's also something to say for asking economics to go into the evaluation and to start to asking the difficult question whether fighting the disease requires so much things like lockdown that the economy goes down the drain, or whether and that maybe there's a tension there, or whether not fighting the disease will in the long run be worse for the economy. But in terms of the question of today, we don't have to solve that problem now between us, but in relating to the question of today, whether science is a public good, we face the question here, fine, but which science to ask whether closing down parts of, or whether making lockdowns or doing other interventions is indeed a good. Which science will answer, or which branch of science will answer this question in which way? Epidemiology and economy are not going to be the same thing. So then we come to our conclusion. Is science a public good? Well, it will not surprise you that my conclusion is an affirmation of what I said in the beginning, which is to say that rather than answering that huge question with a huge yes or no, it is very relevant to start to break it down and to start to look at practices. Because in practices, there is no such thing as science. There are very many sciences that each have different branches and sub-branches that seek to serve different goods and that also have different downsides. So we cannot answer these questions on a general and level in a wide and sweeping way, even if we might want to do that. Philosophy, if it wants to contribute anything, should not try to contribute by making huge statement. It should try to contribute by finding good ways of attending in a fair and careful way to particulars. Thank you.